In recent years, GPs have been nudged into changing their clinical practice through the analysis of proxy variables. Our billing or prescribing or other quantitative measures are decontextualised and misinterpreted. Health economists, regulators and policymakers rely on this analysis to impose rewards or threats, all without any knowledge of how these proxy variables may or may not be meaningful. The impact is not just on patients. There's also an impact on the health and well-being of doctors. The relentless criticism of general practice for not achieving proxy outcomes has had an impact on the sustainability of the workforce. Outcome measurement is an intervention that can and does cause harm. Proxy variables are usually sourced from research studies that recruit white, middle-class urban blokes with first episode illness, people like Norm here. We can't measure the health of people with multimorbidity, intersectional disprivilege, and geographical isolation using Norm's proxy variables. People like Maria have different and often competing health priorities. Using Norm's indicators on Maria is like collecting evidence in renal disease and applying it to the treatment of liver failure. If we measure the performance of the GP working with the most complex, unsupported patients using inappropriate metrics, we can drive exceptional doctors providing exceptional care to focus on easier populations. The surgeons know this. League tables are misleading because the best specialists see the most complex patients with the poorest potential outcomes. When performance metrics are too narrow, only mediocre care looks good. There has been increasing investment in standalone clinics for patients like Norm. Health professionals inside these clinics can achieve enviable outcomes, often because they only accept patients who are inherently suited to standardised care and standardised metrics. However, segmentation has unintended consequences for the patients left behind. The misfits, the outliers, the undervalued core of what GPs do. Remove standardised patients from general practice and GP performance on standardised measures drops. Outstanding care can look very ineffective if we keep using these measures. We could optimise treatment for Norm by standardising care in his clinic and reinvesting the savings we gain into complex patients needing bespoke solutions. We don't, but we could. So, how should we measure healthcare value? We could use metrics that matter to patients. Patients want better function, less distress, and less chaos as they navigate around healthcare systems. Health professionals also want better function, less distress, and less chaos. We need the resources to provide care, the capacity to function. We need a reduction in the occupational and moral distress of being GPs in the current environment. And we need some reliefs from the relentless, low-value bureaucratic chaos that cripples our performance. Every added element in the healthcare system, no matter how worthy, increases chaos. Increase the capacity for capability, comfort, and calm in our consulting rooms, and we increase the capacity of general practice to provide effective care. So what measures do we need to increase the capability, comfort, and calm of the profession and the patients that we serve? Since we cancelled beach funding, we really have no idea what GPs actually do. Lots of people feel they could do what we do more effectively and efficiently, but until we solve the great mystery of what happens during an item 23, this is all speculation, and speculation with conflicts of interest. Let's work with general practice to clearly articulate the current standard of care before we start fragmenting, segmenting, and changing it. Funders and policymakers need to understand the paradox of primary care. GPs follow guidelines less than other disciplines, but we get better outcomes on a population level. If you use adherence to guidelines as a proxy measure of quality, you'll reduce outcomes in general practice. We need to consider the impact of each intervention on the workforce. Every time non-experts nudge us towards inappropriate standardised care, general practice loses its own capability, comfort, and calm, and the performance of general practice falls. Every intervention needs to articulate the impact on the patients left behind. Complex healthcare systems privilege those with literacy, health literacy, and resources. Primary healthcare, particularly in mental health, is like a website full of dead links that are doors to nowhere. We need to measure this sort of healthcare waste. Outcome measurement is not neutral. It's an intervention, and it deserves the same consideration, care, and governance as any other intervention. This means GPs, including GP academics, in the design and evaluation of interventions involving general practice.